All right. Just kidding. All right. Can you guys hear me? Good. Cool. Good morning. Welcome. I know it's been a long time since I have had the opportunity to teach you guys. So we are going to jump right in. Does everybody have the slides downloaded in their preferred method and all that? Perfect. All right. So as some clinical objectives, understanding the etiology of chronic asthma and acute asthma exacerbations, being able to identify the risk factors and the triggers. So of these objectives, as Dr. Hersey said, we are going to make the questions straight from the objectives. The words that are blue and bolded, those are the questions. So if you can't identify a trigger by the time you just okay? Making sure that you can recognize the clinical presentation of chronic asthma as well as the exacerbations, being able to confirm an asthma diagnosis. So we'll talk about that to an extent today. Assessing symptom control based on patient-specific factors. So how can we better control a patient's asthma based on how they present to us at the time? Developing a treatment plan and evaluating the severity based on the stepwise approach, identifying adverse effects and safety parameters, which makes sense. Evaluating appropriate doses and dosing strategies for all of asthma management, and then creating an asthma action plan and managing asthma exacerbations. So pretty much learning what is asthma, how do we treat it, how do we handle exacerbations. That's pretty much the whole. Okay? For the science, we want to demonstrate an understanding of the structure-activity relationship of the drugs that we went over, identifying the mechanism of action of those drugs and how that correlates to the adverse effects. So you should be able to do this with all of your drugs, top 200, other PT models. If you can figure out how it works, most of the time you figure out why the side effects are the side effects. Okay? And then given patient-specific scenarios, applying the concepts of those mechanisms of action and adverse effects of anti-inflammatories and pharmacodynamics. Okay? So use these two to make your study happen. Promise it's going to be very straightforward. All right, so let's jump right in. So what is asthma? Starting with the 2024 GINA guidelines. You guys remember this from Air Lab last semester? Inhalers, MDIs, BPIs. Okay, cool. So I know this is 2024. And I'm probably like, I can call it this 2025. The asthma guidelines come out every year in May. So we don't have 2025 guidelines yet. But looking at 2022 and 2023, they haven't changed a lot, so I don't anticipate a lot of changes when they do come out in 2025. But since we are always ever learning, make sure that when you get to your rotations and your apneas, what have you, double check and see if anything has changed between now and then. Okay? But it is respiratory disease, which makes sense for pulmonary, and classified by respiratory symptoms, activity limitations, as well as flare-ups or attacks that could result in urgent medical attention. Okay? A lot of people think that asthma is very nebulous. It's not a big of a deal. Like, you're just having trouble breathing. Yeah, you're having trouble breathing. Like, you breathe and you don't realize we're breathing, you don't think about it, it just happens. So when it's not working, it can be fatal. Okay? All right, so really quick on some epidemiology. It affects about 300 million individuals worldwide. 1 in 13. So there's a little over 13 people in here. There's probably at least 3 of us, because I'm one, who have asthma. Okay, well, we already found our 2. There's 3. So it happens more often than you think. Whether you plan to go into community, hospital, and care, managed care, you are going to interact with patients who have asthma. Okay, so this is very important. Some people think, oh, this is just for doctor's offices and community pharmacy. I don't work in the hospital. A lot of people go to the hospital because of asthma. Okay? So our highest rates are found in Black and Puerto Rican adults. If it's in red and you can barely see it, it's because you don't need to be able to see it. Okay? If it doesn't follow the red projector, we're all African Pacific. but this is here for completion, so that it makes sense. More often found in female adults and male children. Okay? Can you grow out of asthma? Is probably your question because this is the opposite. Yes and no. Kind of. A lot of times it's just you may have to learn how to manage it better so that it doesn't get itself involved. Okay? Alright, so what are some disparities found in the US? The most prominent drivers are the structural determinants of racial inequalities and the social determinants of health. So most often, the reason why there is that disparity is because of access to care and things like that. But we also have biological determinants and behavioral determinants. So when we get into triggers, not taking allergy medicine every day as a patient with asthma is going to increase that risk as well as the allergies. Okay? All right, so what are some triggers? When you think about asthma and when you think about the word triggers, what are some things that you guys would probably think would be a trigger? I know y'all have the slides, so you should have it. Pollen. Exercise. Smoking. Pollution. Good. So we have inflammatory factors. So respiratory infections, allergens, environmental allergies. Things we kind of just talked about. We also have irritants, so there is the difference. Irritants are things like weather changes, which is separate from the pollen. So like my asthma is really bad when it starts to get cold. Weather changes, not just it's in spring, there's pollen there. Strong odors, which is why we have had to add to the syllabus to not wear very strong perfumes and colognes and things like that, because strong odors can trigger other things. Tobacco and pollutants are also different types of irritants. Then we have some physiological factors. So stress and emotion can trigger someone's asthma. Exercise, viral infections, GERD, what's GERD? What's the regular word for it? Heartburn, acid reflux, yes. So cough, cough, and wink. Yep. Food additives, which is like a myth, but not really. And then medications, so beta blockers, aspirin, and NSAIDs. So when the question says what medication should we avoid for patients with asthma, so like I said, right? So it doesn't really matter what type of your trigger it is, they are all considered triggers. Category is kind of, okay? What questions do you guys have so far? Good?
If you don't have anything, let me get back to that aspirin-induced asthma.
Mm-hmm.
So we remember that in self-care when I taught you about some of those NSAIDs and probably aspirin is one of them, it inhibits COX enzyme, right? That was one of the mechanisms. But inhibiting COX basically leads to, like, there is going to be a concept where you talk about aspirin-induced asthma. What's really happening there? Because that whole pathway, do you remember? At least visualize in your brain the whole pathway of how arachidonic acid gets down into prostaglandins and leukotrienes. Okay, and we discussed about leukotrienes yesterday. If you're going to inhibit prostaglandins as such for pain and fever, you're not inhibiting the leukotriene pathway. And what did we discuss about leukotrienes yesterday? Leukotrienes are 1,000 times more potent than histamine to cause bronchoconstriction. So we are still letting the leukotrienes to form, and that can induce constriction and exacerbate the asthma condition. So watch out for that question. It's a very important NAPLEX-based question about aspirin-induced asthma and what drugs can be helpful, which will dive much deeper. But that is one thing which you have to really, as one of the trigger. Like, why is a drug used for fever end up getting an asthma? The answer is that that drug is inhibiting one pathway but not the other. All right. Thank you.
All right. Yes.
Like ACE inhibitors can exacerbate asthma.
Well, that's only a small list. It's a very small list.
Oh,
we're coming back to more.
Oh,
good job. Yes. All right. So some symptoms. The most prominent symptom when we're talking about asthma is going to be wheezing. Sometimes it's audible, sometimes it's not, but you are going to hear wheezing, or they are going to be wheezing. Okay? Does everybody know what wheeze is? Sounds like, feels like, you took the steps all the way upstairs with your book bag, and your coffee, and your keys, and your coat on after walking from the parking lot. Yeah? Wheezing. You're also going to hear or see coughing. It's going to be a dry cough, so not a wet and puffy cough. It's not going to sound like you're sick. But that dry cough, it feels like it sounds unproductive. Some chest tightness. You may hear a patient say, I feel like there's an elephant sitting on my chest, or just a lot of pressure on my chest. Lying down hurts more. Why? Gravity is pushing down on your chest. Okay? And of course, shortness of breath. They're also going to experience flare-up episodes. You may hear those as acute asthma attacks, asthma exacerbations, anything of that nature is something that we want to address. Sometimes these asthma symptoms can resolve spontaneously. So sometimes it's just they need to sit down, maybe get some water. Other times they need to have medication for those symptoms to be resolved. Okay? So just because the patient doesn't have their inhaler, your friend has asthma, they don't have their inhaler on them, sometimes they will be okay. It's not a, oh my gosh, I can't believe what are we gonna do? A lot of times it's okay. The intensity and the frequency of these symptoms can vary. So sometimes the symptoms are really, really bad, sometimes the symptoms are really mild, sometimes it's happening more often, sometimes as a lot of them once. Okay? However, the symptoms are often due to some sort of trigger. So what do you think is the number one way to manage asthma? Avoiding triggers. Y'all are halfway there. Love it. All right. So we talk about asthma control. Again, y'all are halfway there. So here are the guys. We want to think about symptom control and then controlling the future risk of adverse outcomes. Not adverse effects. That's about drugs. Adverse outcomes. So how can you prevent asthma attack from happening? Okay. So in symptom control, you want to think about the words partially well, partially and uncontrolled. When the question says, how do you identify or classify this patient's symptom control? Well controlled, partially controlled, uncontrolled. Okay? When we think about future risk of adverse outcomes, we want to consider what's some modifiable risk factors. There's going to be a lot of risk factors, and some of them we can actually do something about. We also want to look at those pulmonary function tests, PFTs. That is a medical terminology you should be familiar with. Okay? What do you think a PFT is? Pulmonary function test, yes. And we think that is. But just like describe what are we probably figuring out by this? The function of your pulmonary system, how well your lungs are or are not working in that. Okay, so it's not this big, I don't know, this is such a medical term. No, just how well are your lungs functioning? Test to figure it out. Okay? You run the slides?
No?
Yeah. That's correct. All right, so we're going to go through symptom control first, and a lot of your questions are going to come from here, so I'll finish. Cool. All right, so when we think about symptom control, there are 4 questions, yes, we need to know them. There are 4 questions that you always want to ask or find the answer to determine their symptom control. Okay? So question number 1, are they having daytime asthma symptoms more than twice a week? If it says they're having symptoms several days, that's probably more than twice. Okay? So daytime symptoms more than twice a week. Any nighttime awakenings due to asthma. Any means 1 or more. Okay? If they need their reliever for symptoms more than twice a week, so they're having those daytime asthma symptoms more than twice a week. But remember, the symptoms can resolve spontaneously or in results of medication. So if it's not resolving spontaneously and now they need their medication, well, that's a check mark for question number 3. Does that make sense? Okay. And then number 4, any activity limitations due to asthma. Had to stop practice, couldn't play with the kids, had to do the Ubers or walk home, any activity limitation. Okay? So, depending on how many of these questions they answer yes to, if they are well controlled, they should have all no's. No guesses. That makes sense, right? Well controlled, you're not having daytime symptoms, you're not doing any other, you're not waking up at night, you're not having activity limitation. 1 to 2 is going to be partly controlled. 3 or more, or 3 to 4, same thing, It's going to be uncontrolled. Okay? So we need the medication when we get to 1 to 2 and 1. We're going to treat partially based on their symptom control, which is why, in order as a pharmacist to recommend the medication, I need to know their symptom control. Okay? For this reliever needed for symptoms, the little asterisk is at the bottom. It does not include if they're taking it before exercise. So if they're taking it before basketball practice to prevent, that is not going to be a yes. Okay? This is I walked up the steps and I couldn't catch my breath and I'm still wheezing and still short of breath. The symptoms are not resolving on their own and now I'm trying to. Yes? He's going to put it at asterisk. They say, hey, the teacher had the asterisk and the font was real small at the bottom and you never put attention to it and I was answering the test. Please don't miss the asterisk. Good? Yes. So I think it'll actually make more sense in the practice question.
Okay.
Alright, so we're going to start here without the case. This patient has daytime symptoms more than twice a week. They are having nighttime awakenings. Those symptoms are resolving spontaneously, so they do not need their medications more than twice a week. And they are having activity limitations. What level of control would you classify this patient?
Uncontrolled.
Uncontrolled. Why?
Because
3 symptoms or more. Okay? Any questions about this? Copy and paste the test, okay? Alright, so again, KT is a 14-year-old female with asthma who wakes up twice in the past month due to asthma and experiences symptoms 3 to 4 times per week, which require her to use her albuterol and sometimes miss spitting practice. What is her symptom control? So now we don't have those questions and they can give us the check marks. So how many symptoms does she experience? 4. I give you 3 and a half. Well, if you pick 3 or 4, what answer would you get? Uncontrolled. Good. Does this make sense? You should be able to do this. Okay? Patient comes in and they just explain this to you, or a parent explains this to you. You don't listen to everything you say, and then go ask them the 4 questions. They just answer the 4 questions for you. Okay? Use the answers that you already got to check these questions for yourself to then determine your level of control. Alright, PD is a 25-year-old female who just started pharmacy school. She has not had any nighttime awakenings since starting Flovent. She is trained for triathlon and uses her albuterol 5 times per week before exercise. What is her symptom control?
0.
I'm nervous. How many symptoms does she have? 0. Okay? So where it says she's trained for triathlon and uses her albuterol 5 times per week before exercise, that is the asterisk. The check mark is not a check mark if the inhaler is being used for exercise. Does that make sense now? I'm here. The study guide's right here. Okay? Any questions? So what's her symptom control? Well controlled. Okay? Last one. KG is a 64-year-old male with asthma who watches his grandchildren 3 times per week. He complains of not being able to play with them, and this requires him to have to use his reliever. What is his symptom control? So how many symptoms are you having? So what are the 2 symptoms? Activity limitations, use of inhaler. This is not exercise, right? I mean, we try to sometimes turn our watch on the kids or like walk the dog, but that's not really exercise. So just try to cheat, but yes. So 2, so what level of control? Alright. Okay. Could you argue that him needing his inhaler, thus the activity limitation, leads to 3, and therefore uncontrolled, maybe. But don't read more than what the question is telling you. Okay? The question only says activity limitations and using as an inhaler, use those 2 for now, and go with that. Sense? Cool. Alright, so we talked about symptom control. Any questions about symptom control? Cool. So moving into future risk of adverse outcomes, thinking modifiable risk factors and PFTs. So let's start with the risk factors. Major independent risk factors for exacerbation, meaning either of these on their own with no other risk factors is a major risk factor. Okay? So some disease states, you need 3 of these to be major, you need 2 of these to be major. But ADHD, you need 5 to be classified as it. Either one of these is automatically considered a major risk factor. Okay. So more than one severe exacerbation in the past 12 months, or at least one, or being previously intubated or in the ICU for asthma. Either one. So every time my asthma is very uncontrolled, and I'm very, me and patient first, keep my car flat, okay? And every time I would go, first few questions they would ask, have you had an exacerbation in the past year? Have you ever been intubated or in the ICU? And the person was like, why not always ask me? I said, no. Because these are major independent risk factors. Nothing else matters after that. Okay? When you think about risk factors for medication side effects, so what is going to increase the risk that a patient will have side effects from your medication? We have systemic and local. So systemic side effects would be if they have been on frequent oral corticosteroids. What's an oral corticosteroid? Prednisone, dexamethasone. Okay, so they have been on frequent oral corticosteroids. If they are on high dose and or potent ICS, inhaled corticosteroid, they're on it a lot, which is why the guidelines changed several years ago. That's going to increase their risk factor for side effects. If they are taking a CYP450 inhibitor, going to increase their risk for side effects. There should be some examples in the notes of this slide, but if you don't know them specifically, we'll worry about that in advance. Okay. For local side effects, same thing, high dose and or potent ICS or inhaler technique. That makes sense, because if you're not taking your inhaler correctly, what's a common side effect of an ICS? Thrush. So if you're taking it improperly, you're more likely to have thrush. Does that make sense? Alright. So maybe modifiable, maybe not modifiable. Whether it's modifiable or not is not as big of a factor as the fact that we want to adjust as many of them as we can. Okay? So medications, using a short-acting beta agonist, more than one canister per month. How many of y'all work in community pharmacy? How many of y'all know how many puffs are in albuterol? 200. If you do math, 200 puffs, whether they're normal instructions. 1 to 2 puffs every 46 hours, and then you do short spread. You do the math, the inhaler is going to usually max out to like 8. But if you need your inhaler every 8 days, we need to get you more control. Okay, so needing more than one inhaler in 30 days is a risk factor. Okay? Inadequate ICS dose, the dose is too low. Non-adherence or improper technique. Not being prescribed an ICS plus formoterol at all. Increased risk factor. I've been fighting with my insurance company since January. They do not want to pay for an ICS plus formoterol. I'm like, you all are increasing my risk factors. Comorbidities, so other conditions that would increase their risk for future exacerbations. Obesity, chronic rhinosinusitis, GERD, confirmed food allergies, and pregnancy. So some of these you can't really modify. Some of these you can't. When we think about non-pharm treatment options, think about triggers, how can we address those? Think about risk factors, how can we address those? Okay? Exposures to different things, so exposures to smoke or smoking. So they will always ask, are you currently or are you a former smoker? Air pollution is increasing our need for wearing masks. Pre-COVID, post-COVID, outside of COVID, wearing a mask, especially when I live in North Carolina, my asthma's great. Then I go back home, I said, oh, welcome home. Allergen exposure. Can I decrease allergen exposure? Yes. How? Staying indoors. That's all I can. Lung function. So a low FEV1, which we'll talk about that in a minute, but if an FEV1 is a PFT, how modifiable do you think it is? Very modifiable or not modifiable? Middle social health functions, probably not modifiable. Okay? Also having a high bronchodilator reversibility. So again, we're going to come back to this. Circle this middle asterisk by it and say, see diagnosis slide. When we get to the diagnosis slide, that will explain all of these terms right here. Okay? And then putting all of the patient into context. So remember, we are giving patient-centered care, not only guideline directed care. So we want to consider the patient. And at that point, we're thinking, what are some psychosocial and socioeconomic problems? The patient can't afford an inhaler. Well, I can't really modify it, so we need to modify the treatment instead. Okay? Psychosocial and socioeconomic problems. Any questions so far? All right, so having one or more of these risks, which means having at least one, any one of these increases the risk for exacerbations, even if the symptoms are well controlled. So even if the patient is well controlled, we had a patient who number 0, we all said well controlled. If she had any of these risk factors, that's still going to increase her risk for a future exacerbation. Okay, so we can't just say, oh, they're well controlled, they'll be fine. It might be, but not necessarily. Okay? All right, so how do we diagnose asthma? That little asterisk she put, so their slide. Okay? So number 1, they have to have a history of respiratory symptoms. So at least 2 symptoms, more than 1. What were the symptoms we talked about? Easing, shortness of breath, coughing, chest tightness. Okay? So more than 1 of those. If their asthma is worse at night or worse when they're waking up. So either going to bed or waking up in the morning. Their asthma is often triggered by exercise, laughter, allergens, or cold air. So not just these, remember the triggers from before. It may appear or worsen with viral infections. Patients who get viral infections and also have asthma, we want to really manage that a lot faster. Which is why the passive history is really important. That collection piece is really important. All those things we talk about together. It's really important. Because how are you going to know what the triggers are? How are you going to know what symptoms are happening? How are you going to know, oh, you're here for a viral infection. Oh, wait, you also have asthma. How would you know that unless you collect all that information? Right? And again, the symptoms can vary in frequency and intensity. But diagnosis point number 1 is more than 1 symptom. They have to have had symptoms, not just one that happened today, but like a history of symptoms. Okay? So that's one piece. The other piece is variable expiratory airflow limitations. What? So their airflow, expiratory, so their exhaling abilities are limited and varied. And so their ability to breathe regularly changes on a regular basis. Okay? So spirometry, we need both of these bullets. So that spirometry we talked about is a PFT. Make sense? We'll go into how to read that. So having at least 1 incidence of a reduced FEV1 FVC. Definitions on the next slide. Right now, you just need to know a reduced spirometry at least once. So the goal is for children 0.9 and up is normal. And as we classify adults as 12 and up. Think about treatment, it's 12 and up. Think about medication therapy, it's 12 and up. When you think about children, we're thinking 11 and younger. Okay? For adults, 0.75 or greater. Reference ranges will be used. Okay? So if their FEV1 FVC ratio is 0.6, would that be a reduced FEV1 FVC? Yes. And if it is, these numbers are the normal, 0.75 to 0.8 or greater. So just think greater than 0.75. If it is not greater than 0.75, then it is reduced. Okay? The second part is significant bronchodilator responsiveness or reversibility. So that essentially means that their lungs respond in a significant way to a bronchodilator. Who does not have asthma? Okay, if I get just a bronchodilator, she does not have asthma, we are not going to see a significant change in her bronchodilator, in her FEV1, which is how we will know that she does not have asthma. So then you're thinking, well, what's considered significant? I'm so glad you asked. If the FEV1 increases by more than 12%, so getting back into the calculation, okay? If the FEV1 increases by more than 12% and 200 milliliters from whatever their baseline was within 15 minutes. So if we give this a guess, let's say her FEV1 is 60. What's 12% of 60? Right, y'all actually know the names. 12% of 60. 7.2, so 60 plus 7.2, 67.2. If we don't see her numbers go from 60 to 67.2 in 15 minutes, she doesn't have asthma. Okay? For me, you're going to see it go up in about 5 and more than 12. Sense? Alright, so we need symptoms. We need a history of symptoms and those variable expiratory airflow limitations. So reduced ratio, increasing 12% with bronchodilator. That is what equals an asthma diagnosis. So before you had a lot of questions of, what if they just have symptoms? Or what if they just have this? They need to have both. Okay? So essentially all three, because underneath the variable respiratory airflow limitations, you have reduced FEV1 FVC and the significant bronchodilator. Any questions about diagnosis?
So does it have to be like only one of the diagnosis of symptoms, or it has to be like three or all of them? To
Repeat your question.
yeah, like for example, like for the history of respiratory symptoms, it has to be more than one symptom, or worse at night. Do it have to be like all of them, only one of them too?
So the symptoms, that more than one symptom can happen at night or on day. That more than one symptom can be triggered by laughter, allergens, exercise, or cold air. That more than one symptom can appear or be worse with viral infections. But the whole point is still a history of symptoms. So it can't just be I was short of breath going up the steps. It's I'm short of breath every time I go up the steps. Empty-handed, with my little bag, 1 flight, 3 flights, I'm always short of breath in all these different areas. Plus, when we do the objective findings, so that we have subjective findings, talk about when your case is on Friday, we have subjective findings, history of symptoms. We have objective findings, PFTs, changes that we talked about. The subjective plus the objective findings equal that asthma diagnosis. Does that help? Good question. Any other questions about diagnosis? All right, this is where it gets fun for me. So let's get you a whole bunch of alphabets now. Like, what is this FEP1? What is FEC? What are all these letters? FVC, forced vital capacity. Okay, that is the maximum air, maximum amount of air that you can exhale in one breath. So the test is going to have them breathe into that tube we're talking about. Breathe out as much as you can, as fast as you can, or as long as you can. The system is going to measure that at different time intervals. Okay? So you should notice that under that line is just turned blue. That is forced vital capacity. That's all the air that you breathe out. All of it. Makes sense so far? Okay. Forced expiratory volume, so FEV1. We think about the volume of air is always in liters. Okay? That is the maximum amount of air that you can breathe out in second number 1. So we're going to breathe out for as long as we can. In this example, the patient was able to exhale for a total of 6 seconds. Yes? On the x-axis, we have time. On the y-axis, we have volume. They were able to exhale for a total of 6 seconds. They were able to exhale whatever FEV6 equals, which is their FEC, the total amount of air. In the first second, the green box, is your FEV1. So what was the ratio that we gave before? FEV1 over FEC. So how much air can you breathe out in the first second, divided by all the air you can breathe out. Whatever that percentage is, should be greater than 0.75 or more. Make sense? Alright. So the variable expiratory airflow is the FEV1 over FEC. A little over all of it. So when we think about a patient who has asthma, this blue curved line is a normal person's FEC, which inside of that we calculate your FEV1. The red line is someone who has obstructed airflow. Okay, I want to use this in COPD also, because this is just obstructed airflow, just used to also diagnose asthma. But if it's obstructed, now that FEV6 or FEC is a lot lower, right? It's significantly lower than the blue line. And how much air are they able to breathe out at that FEV1? You guys see the difference? That reduction causes a reduction in the ratio, which is how we diagnose asthma. And you're probably like, we don't diagnose asthma as pharmacists. We don't diagnose yet. We don't diagnose yet. But also, if I'm going to make a recommendation, I want to know for myself if the patient really does have a condition that I'll tell you that they have, so that I can make sure that the recommendation I'm giving you is appropriate to an accurate diagnosis. Okay? So I might not be billing for a diagnosis, but I am treating to a diagnosis. Now I'm going to show you actually have that.
How about if you, do you find yourself in the situation that you doubt the diagnosis and you refer the patient?
No, but sometimes as a pharmacist, we're the first person who talks to a patient. So I might talk to a patient and recommend that we get PFTs because based on the symptoms, I suspect that they may have asthma. I may, they only saw their doctor once. The doctor recommends them to me. Not sure what to do. Please recommend them. And I have labs. You're going to have labs. You're always going to have labs. It's just not a reader. So I need to read these labs and be like, oh, based on these labs, they have asthma. Therefore, I recommend blah, blah, blah. Okay? So now we can see that this FVC is significantly lower than the green box because now the airflow is obstructed. What questions do you guys have? Sure. So,
So as soon as it's below 75, that's a sufficient enough diagnosis.
I need all three. So I need it to hit below 0.75 for the ratio. I need, when we give a bronchodilator, usually they'll give a bronchodilator in the office. Take the PFTs while you're short of breath, All right, while we wait for those results to kind of print out and all that, try this inhaler. We'll just wait 15 minutes later, go do the test again. We should get the reduce. Now we already had the reduce. We should see if the change is greater than 12%. And it came in because they had symptoms. So always go back to you need all of these, not just they have reduced FEV1. Maybe you took the test when they walked up the steps. Maybe there's some reduced FEV1 at that point. Okay? We need all of them. Alright, so PJ 13 referred to your clinic after complaining of chest tightness and shortness of breath at football practice. Do we have symptoms?
Yes.
Yes. Partly controlled, well controlled. Partially, because those are two symptoms, but that's still one check mark for now. Okay? You perform PFTs and PJs are below. So pre-treatment, it was 68 liters. Okay? After treatment, it was 85. The FEV1 FVC ratio is 0.71. Okay? Does he meet criteria for diagnosis? Let's walk through it. So if pre-treatment was 68, what should we look for as a 12% increase or more? Who's math?
70 to 70%.
So it needs to be more than 72.8. Okay? So 12%. Hold on. I probably changed the numbers over the years and only changed part of the numbers. No, 76.
76.16.
Mm-hmm.
Yeah.
So you want to do 12% of 68 plus 68. Okay? The same way you figure out taxes. How much are taxes in the state of Maryland? Y'all shout. How much are taxes in the state of Maryland? Oh, jeez. 6%. Okay, taxes are 6%. If you want to buy a shirt, that's $20. And you're like, I only have $25 in my hand. $20 times 1.6 or 1.06, whatever that number is, will tell you the total price with tax. This is the same thing. Okay, so 68, if you want to do 68 times 1.06, you should still get 76.16. Okay? So we are expecting that number to be greater than 76. After treatment, what did we get? 85. Is that greater than 76? So do we have a significant bronchodilator reversibility? Yes. Okay. This part right here is the 12% significant bronchodilator reversibility, et cetera, et cetera. Okay. Is the FEV1 FVC reduced? What was normal? 0.75 or greater. So is this number reduced? Yes. Okay, so we're 2 out of 3. Do they have symptoms? Yes, so we're 3 out of 3. Does he meet the diagnosis criteria? Yes. It's also asthma, so we have these reference ranges. He has symptoms. His FEV1 increased by 12%. The ratio is less than 0.75. He's 13. Remember that asthma adults are 12 and older. Okay. Also use the cheat code. Well, yeah, use the cheat code when I give you the reference range that says adults greater than 12 years. So, sense? All right. So, what is the stepwise approach to managing poor symptom control? One, we want to watch their inhaler use technique. Make sure that they're using it correctly. Go back to the fall, think about how to counsel patients on how to use an inhaler. Okay? Then we want to discuss their adherence and if they're having any barriers to use. If they're not up to taste, is it difficult to afford, is it difficult for them to use it? Any barrier of any kind, any lack of adherence. Then we want to confirm, okay, well, do you really have asthma? Because again, we gave Jessica bronchodilator, she does not have asthma. we're not going to see any significant changes in her ability to breathe. Okay? So we want to be able to confirm that she actually has it. Then we want to remove or address those potential triggers. What were some triggers? Pollen, smoking, exercise. Good. I'm not saying don't exercise, so that'll be on our slide. So. Assess and manage those comorbidities and risk factors. And then maybe we need to increase our treatment. If all of these things have already been done, it's like, it's still struggling. Maybe we need to increase the dose, increase the regimen or something. 1 second. If that doesn't work, refer to the specialist. Okay? Just.
So why wouldn't we confirm the diagnosis first?
Because some people have inhalers for not asthma. So it might be a matter of maybe you had bronchitis, which I don't know about that. But maybe you had bronchitis, you got an inhaler for that. So we want to discuss, like, okay, well, are you taking the medication that you were given correctly? If you open this up in PowerPoint, that watch patient use inhaler is a link to a video from that old school show House. Remember that back in the day? And he was like, oh, the patient's complaining, oh, my inhaler's not working, I'm having poor symptom control, I don't know why. Oh, show me how you're using your inhaler. And she's like, shh. Maybe that's why it's not we might need to fix that first. Because I don't care whether you have asthma, whether you have COPD, whether you have bronchitis. Using it correctly will fix what it's supposed to fix if you use it correct. Okay? Alright, you guys want to take a break? Me too.
Go to the slide. Yeah.
Otherwise, you're too recording.
Thank you. Yeah, who's the precinct? It's a lady. Mine is a lady.
Alright, Alright, so we talked a lot about symptoms, triggers, classification. So subjective, objective, and a little bit of assessment. Okay? After the break, does anybody have any questions? Good? Alright, so now let's get into chronic asthma management. Asthma is a chronic disease that may only present symptoms periodically. Okay? But I don't have asthma today and I have asthma tomorrow. Okay? The funny for you, alright, so a general outline of how we manage it. We want to understand the principles of management, discuss the medication and the strategies, and then offer patient-specific self-management education and implementation. Just go ahead and write on your slide right now, asthma action plan. We'll get simple about it. It'll probably come up on day 3, but without an asthma action plan, you are automatically increasing your risk for infection and asthma-related death. So, not too dark, but okay. So some long-term goals of therapy. Where does this help yourself know? Goals of therapy. Oh,
Management.
and your show note. Where does it go? There's only 4 options to pick from. Plan. Okay. Goals of therapy are. Where do you get goals of therapy from?
Therapy from the guidelines.
From the guidelines. Thank you. All right, let's go back to Kayla for a second. 99-136. Subjective information, where did it come from?
Patient.
The patient. What type of information is in there?
Subjective.
History of person.
History of present illness, past medical history, family, social, and that social is where you're going to find out whether they smoke, are they exposed to smoking, what's their occupation, are they a coal miner, because oh my gosh, please find a job. Okay, subjective. Objective information goes there. Medical records,
provider,
labs. So what type of asthma information is going to go on your objective portion?
Yeah.
Your PFTs. Whew. I got nervous. Assessment, what goes there?
your clinical judgment,
Clinical judgment, rationale, guidelines. So more specific guidelines. Evaluating the current therapy. So are they controlled? Are they uncontrolled? Are they well controlled? Are they partially controlled? Where do we put the symptoms? I just told you subjective, and then what part of the subjective? The HPI. Okay, I will go more and go study these slides. Study the social template, okay? Study the social template. Okay, so the symptoms are in our subjective. This got that from the patient. You then made an assessment that based on these symptoms, they are partially controlled, not controlled, low controlled, whatever. Yes? Then you look at the medications from both subjective and objective and decide they are or are not on your therapy, which we don't know how to do that yet. But you also want to say, per whose guidelines? Y'all all got slides and nobody's scrolling right messed up. Everybody has the same slides. Per whose guidelines?
Gina.
The GINA guidelines, thank you. Per the GINA guidelines, patient is classified as well controlled or uncontrolled or partially controlled. Treatment is or is not appropriate. Goals of therapy include, this is the answer to that part of your case when it comes to coming. Goals of therapy, alright? We all up to speed? Try to finish this up real quick. Okay, plan. What's in the plan? Continue, start, stop, initiate, discontinue something. Monitor for these things. Follow up in this much time as an action plan. Okay, as an action plan goes in the plan. Alright, you guys got this. Alright, so goal, achieve good control of the symptoms and maintain normal activity levels. That makes sense because that's 2 of the 4 questions. Minimize future risks of mortality, exacerbations, fixed airflow limitations, and side effects. Some of that is your objective, your risk factors, your PFTs. And then identify and address patient-specific goals and preferences. So in your assessment, you're not going to say the goal of treatment is to identify goals. Identify the patient's goals and put that as the goal. The goal of treatment is to minimize or maximize patients' ability to play with their range. Okay? Alright, then we get to non-farm. What part of the note does this go with? Non-farm options. Goes into the template, it goes in assessment. Okay, all options go in assessment. Medication treatment options go in assessment. Which option that you picked goes in the plan. Because all these options might not apply to your specific patient. Okay? So treatment option, non-farm interventions, cessation of smoking or cessation of smoking exposure, avoiding occupational exposures, avoiding allergens. So all of those are what? Triggers. So we'll talk about so avoiding triggers. Just be specific about which trigger is appropriate. Physical activity, avoiding medications that may worsen asthma. So those are your beta blockers. That's your aspirin. That's your NSAIDs. That's your ACE inhibitors. Too much of a short-acting beta agonist. It sounds counterintuitive. We'll actually talk about it tomorrow. But increased use of esophagus to increase your risk of future exacerbations. Yes?
Is it because of tachyphylaxis?
It's because of reverse feedback.
Yep.
Mm-hmm. You know what I'm talking about?
Yeah.
Too much of it, and your body tries to compensate, and it actually makes it worse. It's called paradoxical bronchospasm. Okay? So too much of the beta blocker is actually going to worsen. Breathing techniques. So just deep breathing techniques. A lot of free videos on the internet to guide patients through that. A healthy diet, so avoiding a lot of those additives to foods, a lot of the GMOs, MSGs, all the alphabet soups. Avoiding air pollution, dealing with emotional stress. So maybe that means getting a therapist. Maybe that means talking to a guidance counselor, finding a friend, a pastor, whatever you gotta do. Okay? Weight reduction, because remember, obesity was a risk factor, and physical activity should also help deal as well. Vaccination. So every single patient who has asthma must receive an annual COVID shot, annual flu shot, and a pneumonia shot as appropriate. Okay? And then avoiding foods with known allergies. You guys talked about yesterday the pulmonary physiology, and some of this is an allergic response. So if I'm eating a food that I'm allergic to, then my body's going to have an allergic response, which could then potentiate an asthma exacerbation as well. Okay? Any questions about these? It is highlighted in yellow to show you where specific. Okay? So general principles, reviewing the response. Assessing, assess the patient. So confirm if they really have a diagnosis, determine their symptom level, symptom control, risk factors, inhaler technique, adherence, patient preference, and comorbidities. So this kind of sounds like everything we've already talked about before. What section of the note does it go in? Sorry. Assessment. There we go. Then we're going to address the treatment. So that could be adjusting the asthma medication, adjusting some of those non-chronic strategies, treating and adjusting some of those modifier risk factors and comorbidities, and then offering education and skills and training. What part of the note does this go with? Plan. So you have PDCP and self note, care lab, and all come together to you manage anything and do this. Then want to review their symptoms. After you've adjusted the treatment, give it some time, then we're going to review the symptoms. Did the symptoms improve? Have the exacerbations decreased? Have the side effects been little to none? Has the patient been satisfied with both your treatment regimen and the treatment outcome? So it could be, I love that I'm not having difficulty breathing, but I really need this inhaler. It could be, I don't have any problems with the inhaler, but I'm also not feeling any better. Okay? And then we're going to reassess or review that lung function to see if the FEV1 and FVC has it. Alright? So we talk about medications, there's two categories. What do you guys know about inhalers for asthma?
There's rescue.
Okay, you hear me? I love it. Listen, that's half the battle. Reading the question. Maintenance, rescue. What do you guys know from personal experience? We got people with asthma now.
What was the question?
I'm going home, class is dismissed. What do you know about asthma medications?
Oh, they can cause adverse effects as
Okay, say that again. Okay, so there are some that we use every day. There are some that we only use as needed. So do patients have both or just one or the other?
Sometimes.
Hopefully both. Or 2 for 1, which is my new favorite thing. Alright? So, controller, you may hear it called a controller inhaler, a maintenance inhaler. These are the ones that are daily maintenance treatment. Okay? This is the one they take every single day, whether they feel it or not. This one is always going to contain an inhaled corticosteroid. Plus minus something else. I'm saying. The maintenance inhaler is going to reduce airway inflammation. You guys talked about this yesterday from pulmonary physiology. The airways are inflamed and the inflammation is what's causing the constriction. These are going to maintain a reduction in that inflammation. Make sense? Give me 1 second. They're also going to control their symptoms over a longer period of time and reduce the risk of future exacerbations. So who should have a maintenance inhaler? Everybody who has asthma. Every single person. If you come across a patient who has asthma and does not have a maintenance inhaler, are they on appropriate treatment? No. I'm speaking. Ernesto, what was your question?
Yeah, I have a question about some corticosteroids every day. Is the dose since it's a little dose, you're not like
The increased risk.
Yeah, increased risk of like HPA axis or
Mhm.
like.
So the one, because it's inhaled, you're kind of at a decreased risk of that HPA axis, all of that. Because you're also thinking more of a topical administration versus systemic. It is systemic when you think about the drug particles supposed to get on your lung, and then blah 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 blah. You're not going to first pass the bed. You're not going to liver and all that. So you kind of bypass a lot of that. The other part of that is at the end of the day, we're going to talk about ICS dosing, and the goal is for a low or medium dose ICS. When we get to high dose ICS, we're thinking severe asthma, we're thinking monoclonal antibodies, we're thinking specialists. Okay. Reliever inhalers are also provided to all patients for as needed relief of breakthrough symptoms. So if you're taking this every single day, no matter what did we say about the symptoms? Are they always the same or do they change at different times? They change. So sometimes those symptoms bypass that maintenance medication's effects. And now we have those breakthrough symptoms, which is why we have the albuterol or the albuterol. Okay? These are for short-term prevention of exercise-induced bronchoconstriction as well. So that's why that question says she was taking it before triathlon practice. We can use this in advance or prior to exercising to prevent bronchoconstriction. Okay? So if that is the case, then it does not count as one of the four questions. Okay? The rescue is the one we're going to use during asthma exacerbations, or worsening asthma and exacerbations. The maintenance inhaler is only going to maintain. So if you're at a bad state, we don't want to maintain that, so we're not going to use it. Okay? We get to the asthma action plan, we get to management in the hospital, management in the urgent care, you are going to see that we are going to discontinue their maintenance inhaler temporarily, or actually we will put a hold until that exacerbation is resolved from this rescue inhaler that we choose. All the other things about it. Then we will restart the maintenance inhaler. Okay?
Alright, guys. Picking up on this stuff which is learned yesterday about asthma, there are two important hallmark features of asthma we discussed. What were they? Inflammation, and the other one, bronchoconstriction. And then picking on that, what can be the pharmacological therapy for that? If you want to reverse the inflammation, we use anti-inflammatory drugs. If you want to reverse the constriction, we use bronchodilators. Simple. So classifying those anti-inflammatory drugs, which basically are your maintenance drugs, into three different classes. The hormone-containing, which is basically the corticosteroids, and based on all the things we know about corticosteroids, ICS are the preferred because the systemic corticosteroids have deleterious side effects. We'll talk more about that as we do understand the mechanisms. Then we have non-hormone containing anti-inflammatory, which are leukotriene modifiers. Why leukotriene? Why specifically leukotriene? It's the most potent inflammatory mediator which can cause bronchoconstriction. So this is basically in pill form, so anyone who is preferring pills and corticosteroids is really not helping them, then we can probably, and this is mostly a allergic seasonal rhinitis, that's when we go to leukotriene modifiers. Then we have biologicals. Example, omalizumab, IL-5. What is IL-5? You cannot go wrong on one thing, as I told you. Inflammation. So you can go ahead and tell that it's an inflammatory mediator. To be more specific, we discussed about three different ILs yesterday, 4, 5, and 13. 4 for what? IG antibodies, 5 for eosinophils, and then 13 for mucosal secretion. Okay? So we have specific IL-5s, IL-4s out there, which are going to be targeted to one particular eosinophil. So basically, when you draw blood and you find a patient who is not well controlled on this ICS plus SAVA and LAVA, and he's having high eosinophil count, what is the next step or what's the next thing which you can think about to help that patient, will be directly going to eosinophil specific antibodies, which are basically your IL-5 antibodies. Got it? Are you following me? Okay. We're moving to your bronchodilator. These are no-brainers, right? We know sympathomimetics and anticholinergics. Why anticholinergics? M1, M3, and we always know that sympatho is opposite of anticholinergic. I mean, they basically, sympatho basically oppose the effect of acetylcholine, which are cholinergic. So we basically use an anticholinergic to reverse the constriction associated with acetylcholine. So one of the hallmark drugs out there is tiotropium. It's a quaternary molecule compound. And then we talk more about it when we get there. And then we beta-2 agonists. Beta-2 agonists is divided into two types. We have a short and we have a long, SABAs or LABAs. Okay, they are all called as bronchodilators, and again, these are rescue medications. They are not the medications which probably help you for a long-term asthma. All right, so as I told you, I'm going to use this diagram as a template and we build on all the places where we can use the drugs to kind of help, because this is not something which we have not learned from yesterday. So here's the thing, we discussed about allergen. We're talking about the whole pathway again. Whenever a person gets exposed to an allergen, the epithelium detects it, it engenders the antigen processing cells to basically activate which type of cell? Th2 or Th1? Th2. So the Th2 cells get activated. Activating a Th2 cell will cause all the inflammatory mediators to be recruited and released in your system and circulation. Things which we have to worry about: cytokines, chemokines, mast cells. What does mast cells release? Histamine. In addition to histamine, what else does it release? Prostaglandins, leukotrienes, platelet activating factors, so on and so forth. Okay, so most of the idea behind this whole process is like, first things first is inflammation, and basically the mast cells. These are all acute related. Over a long period of time, chronic asthma is associated with airway remodeling. Right, so all these inflammatory mediators are going to create a havoc. They all come, and this is overactivation. Overactivation leads to hypersensitivity and hyperresponsiveness, which finally leads to all the aspects associated with changes in your bronchial smooth muscles. So we got bronchoconstriction, we have vasodilation and angiogenesis, as I told you, and then we also have subepithelial fibrosis and mucous hyperplasia, goblet cell hyperplasia, another way to look at it. But these are all the structural changes which we can expect over a period of time. Okay, and again, this is what we learned yesterday. Okay, how our drugs are going to help. So I have put something in highlighted in red. So first, we have an IgE. What is IgE? IgE is going to come and settle on your mast cells to prime it. So the mast cells, once it's primed, it's going to release the internal contents. What are the contents in a mast cell? Histamine. So we don't want that to be released. So we have to capture the IgE as such. How can we capture an IgE before it goes and primes a mast cell? By using a drug called as omalizumab. Omalizumab captures the IgE, basically means like it's an antigen and it binds to an antibody. Simple. So if omalizumab captures your IgE, it cannot prime the mast cell. Tell me the whole process now. No priming of mast cell leads to no release of histamine leads to no inflammation leads to all the structure changes, no structure changes leads to no constriction, so on and so forth. Okay, I mean, this is basically an injectable formulation. So that's one of the classes. The next one, 4 and 13. We discussed about that. I'm not going to go back again to talk about 4 and 13, but we have drugs out there. These are injectable formulations again, basically capturing specific. If someone understands and again, this is all genetic associated, as I told you. If someone has a higher IL-4 versus IL-13 versus IL-5 versus IL-6, so we have drugs to help them specific for that particular IL. Instead of like really targeting all this, as we understand from pharmacology, we want to be as specific. If I have a problem with eosinophil, I'm going to go to IL-5. If I have a problem with prostaglandin, I go to a prostaglandin. I don't want to like use everything to shut down the whole immune pathway, because we need those inflammatory mediators to basically help us to get through the day. Corticosteroids, these are the drugs probably of choice for maintenance. Inhale corticosteroids basically are going to, the idea behind this corticosteroid is it's anti-inflammatory. It doesn't differentiate between histamine versus prostaglandin versus an interleukin. It shuts everything. It shuts all the formation. So what's the downside? You shut your whole immune system. You're prone to
infections.
yeah. Okay. And again, that's systemic versus inhale. So that's another debate. The idea is that it shuts your immune system to some extent. So basically, why are we shutting the immune system? Because asthma is hyperimmune or hyper response and hyper reactivity. So it's not like something which a normal person tends to have. It's a genetic associated factor where the Th2 activation basically causes a hyper responsiveness. You're trying to shut them down to bring it back to optimal level as much as possible. Moving forward, constriction, bronchodilators, as we understand, and then there is a parasympathetic nerve activation. What does parasympathetic nerve activation leads to? Parasympathetic system as such leads to constriction. So they can use anticholinergics over here to help reduce some of that. And then whatever structural changes, can we reduce the subepithelial fibrosis? Can we do anything to your collagen basement formation? Can we bring new epithelial cells to basically form? We cannot really do anything, so we don't have any drugs out there. Okay, whatever we can really help and prevent is around here. It's mostly your inflammation and to some extent your broncho constriction by using bronchodilators. All right. I just keep going. And again, I just explained this whole thing, so it's gonna be so let's go to a quick knowledge check. Which type of pharmacological therapy primarily targets the modulation of leukotriene activity? Answer. Quick. We just read this. Say. Move forward. Which bronchodilator class primarily acts on beta 2 adrenergic receptors? Beta 2 is sympathomimetics. Alright? Moving forward. Tiotropium belongs to which class of bronchodilators? Anticholinergic. Which pharmacological class therapy includes drugs like omalizumab and IL-5 antagonist? Biologicals. Alright.
All right. Okay, there we go. So as a disclaimer, so we kind of touched on it a little bit before, but now we're getting into the medications. Adults are considered 12 and older. Okay. Using these GINA guidelines, the I is for international. So these are not the U.S. guidelines for asthma management. These are the global, international. They want to call it that. Okay. But remembering that all of the things that you're going to see in the guidelines might not be what you see in practice here in the States. So different providers might use different things because they're following, what works best here based on our environmental factors, based on our patient population, and things like that. Okay? So you may see an as-needed ICS plus LAVA. You may see an as-needed ICS when you're using a SAVA. You may see never using a SAVA alone. Some providers can also practice by open guidelines. When you get it on these in your athletes, they're like, this is not what I'm going to talk about. Remember that they're international guidelines. Okay? Alright, so we want to talk first about what is the preferred controller initiation approach. So controller, maintenance inhaler, how do we decide which controller to pick? Okay? The initial controller, so this is at the time of diagnosis, not we are adjusting their therapy because X, Y, and Z. Patient comes in, newly diagnosed. How do we pick that first controller that they're ever on? Okay? That medication is based on how they present at the time of that diagnosis. So what symptoms did they have? What were their PFTs? Things like that. Okay? So we're going to pick based on symptoms. So let's talk about the symptoms. If they present with symptoms less than 4 to 5 days per week, we're going to start them on step 1. The next slide we'll talk about what drugs are you using for step. Right? So symptoms less than 4 to 5 days a week, start them step 1 or 2. Most of the time we're actually going to start them on step 2 because step 1 is like, oh, only you have symptoms. If they have asthma most days of the week, so 5 or more, think about half a 7 is 3.5, so like 4-ish. We just said less than 4 to 5, so just think 4 or 5 or more. Or if they're waking up due to asthma symptoms more than once a week, or at least once a week. Okay? So if you see that nighttime awakenings, we're going to start the patient. Step 3. See symptoms most days of the week. Step 3. Okay? If they're having symptoms daily, or you started with uncontrolled and maybe it was like very uncontrolled. It's like, no, I'm waking up every night, I'm having symptoms every day, I can't even walk to the store. Okay? Or if they're waking up due to asthma symptoms at least or more than once a week, and they have low lung function, so that FEV1 FEC ratio is very, very decreased. So not 0.71, not 0.65, maybe like 0.3. Okay? Low lung function. We're going to start them on step 4, and we may consider a short course of oral corticosteroids to kind of boost them back to a better baseline. Okay? We're never going to start somebody on step 5, it's always step up or add on therapy. And at that point, you're probably going to refer them anyways. Okay? So we're starting based on how they present the symptoms that they have. So that's why those 4 questions are really important. So, do we need to know this chart? Yes, you do. So save it as your screensaver, look at it before you open your eyes, before you close your eyes at night, put it on your pillow, do whatever you need to do. But do we need to know this chart? Yes, you do. Okay? So remember, we said if you're having those symptoms less than 4 to 5 days a week, we're going to start them on step 1, step 2, which is our low dose ICS promoterol as needed. Okay? They're having any nighttime awakenings, or they're having symptoms most days of the week. We're starting them on that step 3, which is a low dose ICS plus promoterol schedule, which means it's a maintenance inhaler at that point. Okay? If they are at step 4, medium schedule. I put the words in red to just kind of help you condense what you need to memorize. So we're either doing low, it's always ICS plus promoterol, the preferred controllers to start there. So we're either going to do low as needed, low scheduled, medium scheduled, or high scheduled. Okay? If we're at step 5, so we either step up to that point to marry men, usually, not always, yes, we still have a question on step 5 connection. Usually by a specialist, high dose, scheduled for maintenance, or we can add on the llamas, which we'll talk about tomorrow, today. That's what we'll end today. Or we can add on a biologic. So that's that IgE or anti-IgE that Dr. Muhammad was talking about. Okay? The second line here is an alternative option that is still preferred. So when we're thinking about what we're doing, we're trying to spin in that you just talked about. That's going to be your link, secondary and or add-on option. Okay? Tomorrow we'll talk about when would we consider to add or switch or choose those options instead. Okay? So all the colored boxes at the top are our controller inhalers. At the bottom we have reliever, and as you see, a low dose ICS plus formoterol PRN. Where else do you see ICS plus formoterol? Everywhere is ICS plus formoterol. It doesn't matter is it low, medium, or high. If it's scheduled, is it PRN? So the beauty of the change of the guidelines is that now you can have what is called MART, M-A-R-T, maintenance and reliever therapy. Essentially a 2-in-1. So rather than needing one inhaler for controller and one inhaler for rescue, you can have one inhaler that works for both. Is there a question?
Is formoterol a SABA?
Is formoterol SABA? Google is free. That's the common circuit. Is formoterol SABA? What are the 2 SABAs? There's only 2. Albuterol and albuterol. Those are the only 2 SABAs. So what is formoterol? Gotta be a lot. That'll be tomorrow. Okay? But if you think about it, everybody's getting steroid plus a long-acting beta agonist. But right now, in the preferred track one, we're being specific of which LABA we want. The LABA that we want is Morpho, which is why I mentioned. Okay? The alternative control option is based on their control history and patient preference. This beautiful FYI actually meaning the okay? But this is if their symptoms are less than twice a month. For step one. Step two, if they're having symptoms more than twice a month for less than 4 to 5 days a week. Step three is if they're having symptoms most days and waking up to having the same. Step four is the same, step five is the same. So the only difference is now in step one and step two, we have separated how do you pick step one or step two. This is how we pick. But generally, your safest to start at step two. Because you want maintenance or scheduled inhaler. You don't want that PRN. Okay? Alright, so track two, so this is an alternative approach to controllers. Now we're having ICS only for step one and two. ICS in step one is PRN, ICS in step two is scheduled. Step 3, 4, and 5 are low, medium, and high ICS plus any LABA. So not necessarily just for oral. Okay? Then you have your alternatives at the bottom, so you can add the leukotrienes at specific spaces and then maybe an oral corticosteroid as necessary. The other difference with this track 2 is that now we are considering ICS plus SABA for the reliever or a SABA alone. What did we say about SABAs alone? Non-preferred, too much increases risk for asthma-related death, paradoxical bronchospasm, etc., etc. Right? So this is where the guidelines actually started. SABA PRN for reliever therapy. Then as time went on, they did studies in clinical trials and realized, oh wait, maybe we shouldn't be doing that. So inpatient now that you have was only on albuterol for their rescue therapy is not on our preferred treatment. Okay? I will say that ICS plus formoterol is the only one that is FDA approved and preferred for reliever therapy also. So my insurance does not allow the ICS plus formoterol, then I am going to also need a different inhaler for my reliever. Okay? Because that does not say ICS plus LABA, it says ICS plus SABA, which I don't have. It also says for a SABA alone, which I don't have. So if I don't get ICS plus formoterol, now I need ICS plus whatever LABA and something different for rescue. Which is also why I'd rather just pay the higher price for why would I pay for 2 inhalers and I gotta keep up with 2 inhalers doing that. My purse is not big enough for that. So moving on. Alright, when we talk about asthma severity, that is based on what level of controller they needed to adequately control their asthma. So if they're not on a controller, can I determine the severity? Good. If they're not on a controller, can I determine the severity? If they are not on a controller, can I determine the severity? Okay, this is yes. Sure. So severity is assessed retrospectively, which means after the fact. You go back and you look to see what has happened, what worked. It's based on the treatment step that was required for control, can only be assessed after the patient has been on controller treatment for several months. So at least 3. Okay. That severity can also still change over time. But the biggest point right now is it is determined retrospectively after being appropriately managed on a controller for at least 3 months. Okay? So, how do we pick? Well, if it's based on the maintenance inhaler that they're on, that came from step 1 through 5. Step 1 and 2 is considered mild. 3 and 4 is considered moderate. 5 is considered severe. So if they are on a medium dose ICS schedule, what step is that? Hold up. Medium dose ICS plus formoterol schedule. Medium dose.
Moderate.
What step though?
Or
Make sure you answer the question I asked you. That's when we go. 4, which means their severity is moderate. Okay? So when we put it here, this is the chart that I would say you can memorize with the mild, moderate, and severe already at the top. Okay? Whatever slide it is. So they have to have been on this for at least 3 months before we can decide what severity is. If they have not been on it for at least 3 months or they are not on control of therapy at all, the question says, what is their severity? What is the patient's asthma severity? Severity cannot be determined at this time. Okay? You good? Wow. Terrible. Pretend like that's not there for a second. Okay? So symptom control describes the management of your symptoms. Severity classification classifies the disease. We're either talking about their symptoms, they might not have asthma, they can still have symptoms. Okay? Or we might not have a confirmed diagnosis, they can still have symptoms. Severity is classifying the disease as a whole, which means they already have it, thus we're going to have it. Okay? Symptom control is based on those 4 questions in which you get well controlled, partly controlled, these here. Severity classification is based on the current controller therapy, which means it has to be retroactive, and that's your mild, moderate, severe. Okay, so this is your summary slide. You're going to have questions that say, what is their asthma symptom control? Well controlled, partly controlled, moderate, severe. Well, you know that moderate and severe are automatically wrong because that's not symptom control. Does that make sense? If it says what is their asthma severity, it's going to say partly controlled, uncontrolled, mild, moderate, severe. Well, you know that partly controlled and uncontrolled are automatically wrong because they're actually for severity. Make sure that you're reading what the question is asking you and then answering accordingly. All right, so let's practice. Nighttime awakenings. Is that a symptom, or is that a severity, or is that a step in therapy? Symptom. Good. Scheduled low dose ICS. That's that therapy is scheduled low dose should be 2. So which one is that? Alternative and still mild because they're on step 2. Make sense? Alright. Frequent daytime symptoms. Symptom. Medium dose ICS plus formoterol. Step 4, and so therefore moderate as well. Good. PRN low dose ICS formoterol. What step is it? Step 1. So it is mild. Does that make sense how all these different terminologies actually tell you something different? Okay, so make sure that you understand what terminology goes with what. But in this slide here, it's kind of how you can put all of it together in the same spot. Okay, so if you're going to study that, I will put this slide on it with an abbreviation slide on it. Okay? Yes.
Could the scheduled low dose ICS also be water? Or wait, no, because it doesn't have an answer.
Correct. Yeah, that's tricky. That's why I was like, when I see it first. Alright, so we're back to PD. She is a 25-year-old female, currently training for her first triathlon. She has switched therapy and now uses her reliever every day before exercise. Is that a yes of the 4 questions? No, it is before exercise. Okay? She also has woken up twice in the past month with cough fits. Her medications are as follows. She is on Symbicort, 84.5, 2 puffs twice a day, which is now, I'm telling you, it is a low dose ICS plus remote. By test, you need to be able to figure out that it is low dose. We're going to do that next. So for now, she's on a low dose ICS plus remote. How would you classify her asthma control? So control is what options?
Control.
Okay. And how many symptoms does she have? Or what? How many yeses do you have?
Yeah, those two.
Twice in the past month. So we have one, but we have partly control. Okay? Because that use of a reliever before exercise is what that aspect is about. And it does not apply in those situations. Okay? How would you classify her severity? The low dose ICS schedule, is this schedule or PRA? Based on her regimen. Schedule. And so therefore she's ICS plus lamotrigine, low dose schedule. Good. So we're going to take this low dose schedule, which means she's on 3, which means she is moderately controlled. Sense? So these active learning questions are your study guide, which is why I'm going to make them. Okay. DG is a 9-year-old boy who's recently diagnosed with asthma. He currently lives with his grandmother who states, "We've been going through albuterol so fast, the insurance says we can't have it anymore. DG's only medications are albuterol, and he is coughing the entire visit. As soon as you enter the room, you know that it smells of smoke. He has not had any exacerbations since diagnosis. He states he always uses a spacer with his albuterol and just wants to play with his friends at recess." So this is a lot. So break it down, take your time, you can figure it out. So what are his risk factors? Going through albuterol so fast is one. Sorry, I don't go in the order that it goes. So that's a high SABA use. Remember that, more than 1 canister a month. Remember we talked about how many puffs in a can, how often will they pay? They're going to pay every 30 days. If you've been going through it so fast the insurance won't pay for it, that means you're using it more than they're expecting you to use it. Okay? Only medication is albuterol, so he's not on an inhaled corticosteroid at all. That is a risk factor. It also smells of smoke, so we have that exposure. Okay? What is the symptom control? What is that based on? The 4 questions. Okay? So we've been going through albuterol so fast, which means he's using it not necessarily just for exercise. So we can check the question 3, I believe. That says multiple uses of inhaler throughout the week, something like that. Okay? He's coughing the entire visit, so what does he have in daytime symptoms? Okay? He wants to play with his friends at recess. Sorry. So what does that mean? Activity limitations. So how many symptoms does he have? 3. So what level does that put him at? Uncontrolled. This is the level of thinking you want to be able to do on the test. Okay, so if you watch this in PowerPoint mode, it will walk you through just like we're doing right now. Okay? So what is the preferred treatment to initiate? How do we pick the first initial controller? I kind of heard it. So we're going to start at step 3, probably, because he's having asthma symptoms most days of the week. It doesn't say he's waking up at night, but he is having those symptoms most days of the week, which we can imply because you're using your inhaler so fast that the insurance won't pay for it, which means you're using it most days of the week. Okay? So based on that, we pick step 3, which is yes, low dose ICS schedule. Okay? Or ICS plus lamotrigine. What questions do you guys have? Yes.
Second question.
So it's
So the blue ones. Albedo also fast. Coughing the entire visit, so daytime symptoms. Wants to play with his friends, which implies symptom limitation. You can watch it on the recording, but please take a picture. Okay, so it is color coded for that very reason. The greens are the risk factors, the blues are symptoms, the yellows. So that's over. All right, so tomorrow we'll start with ICS. I don't know, is that over?
yes.
Listen, people were still ready to learn, and I'm still ready to teach, but if I can over, I can accept that.
Yes, class over.
Okay, cool. We'll see you tomorrow, and we'll start with ICS, okay?
Thank you.
You're welcome.
Yes.
I mean, it's not so bad. I mean, if it's not, it's like a.
That's my college.